Let's move to BOUT 14. How to select a stand. You have so many things about stand, the technology. For this session, I invite Dr. Kamaldeep Chawla, Dr. Hitesh Shah, Dr. Kamlesh Thakkar, Dr. Kiran Prajapati, Dr. Utsav, Dr. Ronak Shah, Dr. Jignesh Patel, and Dr. Kunal Tambakwala as our chairpersons and moderators. And our speakers, Dr. Priyank Modi and Dr. Mukesh Ladda. How to select a stand? There are certain stand parameters which we need to discuss out. So over to chairpersons to introduce the case and invite the speaker. Dr. Priyank in red corner. Dr. Mukesh will be in blue corner.
So our case is 50 years old, doctor with diabetes, unstable angina, planning to undergo PTCA to tortuous angulated 90% mid-circumflex lesion with large obtuse margin rising across it. The stent parameter that helps in choosing in this stenting would be the criteria what we are going to discuss about. The learning objectives, knowing the architecture of the stent to choose the stent, drug elution patterns versus polymer patterns, and trackability versus radial stent of the stent. So our speaker is Dr. Priyank to start with.
Very good morning to all of you. The evolution is of 50 years. Started angioplasty in 1977, and since we have been using stents 30 years. So comprising them in next 5 to 10 minutes would be a little difficult. So what I would consider by planning this case, the first thing is 50-year female, 50-year. So that is young age group. You would not want complication during these procedures because the relatives are not going to be kind when you have a complication in a young person. The patient has unstable angina, so the plan would be quick in, quick out. You do not want to have a periprocedural infarct. You do not want the patient to get unstable. It is a tortuous circumflex artery, and because there is a large OM coming out from that artery, there would be chances it may get pinched and you may have to convert it into a bifurcation PCI. So these are some important aspects in the clinical history where it will help us determine how we are going to proceed. To all my colleagues who are in the first 10 years of practice, acute complications are important to be avoided. I have mellowed down from post-dilating at 24 to 28 atmosphere now to 16 to 18 atmosphere. It is after having 10 plus perforations. So what my boss used to teach, it's important to live, because if you live, you have another day to fight for. So whenever you have to select something, acute for me is more important. The patient should go well. Now, just going through the history, all started with balloon angioplasty, 1977. Bare metal stents came in, Palmer-Schwartz, 1986-87. Problems with bare metal, restenosis was on the higher side. In the next decade, we had drug-eluting stents. And since last 20 plus years, this is the era of drug-eluting stents, and we are getting with better and better drug-eluting stents with time. So The biggest problem with just balloon angioplasty was there was an high risk of acute abrupt closure. The patient had MI next 24 hours because the artery recoiled and closed down. So as much as 5 to 10% of the patients have that. 20% required emergency CABG. Restenosis was very high, 30 to 50%. And that is where we thought that we require a scaffold to prevent that recoil. And that is where we had the first bare metal stents. With bare metal stents, the restenosis reduced to 20%. And the most common cause that was found was neointimal hyperplasia, and that is where drug-eluting stents came into picture. The first drug-eluting stent which came into picture was the Cypher stent, and from that we have progressed a lot. So when I have to select a stent in this particular patient, what would be the key factors? The deliverability of the stent, the side branch access, what is the safety, what would be the chances of stent thrombosis, and what is the long-term freedom from restenosis. Now, why is stent design important? The chances of dog boning. Dog boning is where the center does not get inflated and the peripheral stents get inflated more. That causes more chances of dissection and sometimes perforation. Stents do recoil, particularly if the lesions are hard. Chances of restenosis, chances of foreshortening and other issues also persist. So when I have to select a stent, the first important aspect is the performance and ease of use. What is the deliverability of the stent? So what is the overall ease that will be for me to deliver the stent to the target lesion? What is the trackability? So what is the amount of effort or force which is needed to move the stent system forward? The good stent strut apposition, so the ability of the stent to sufficiently expand so that the struts would abut against the vessel wall. Now, further in stent selection, what I would want is a good acute angiographic result. So what is the radio opacity of the stent? The visibility of the stent under fluoroscopy. What is the scaffolding? So the amount of metal which is supporting so that there is not much of plaque prolapse, particularly in acute situations. What is the conformability? So that is the flexibility of the stent to go through the whole system. What is the placement accuracy? So how much accurately is my stent placed over the lesion? Am I missing upon something? And that largely depends upon what is the marker visibility, what is the amount of longitudinal shortening that can happen, and what is the balloon overhang, because more the balloon overhang, more chances of distal dissections. With that, all the desirable stent characteristic I would want in my stent is low crossing profile, high flexibility, high stent or host biocompatibility, particularly of the polymer, high radial strength, low metallic surface area, favorable radiographic properties, good trackability, and easy deployment. Now, we go a step forward before we discuss the case is to first discuss the stent design. So in the stent design, the three most important aspects are the struts, the crowns, and the connectors. Now the struts and the crowns will form your ring, and whatever play has happened in the last 20 years is how good we get or how good the industry and the scientist gets with the connector. So how we are going to connect the different struts makes all the difference in the progress of first to second to third generation of stents we have right now. The most important aspect what was learned in the initial part was the stent or strut thickness, which was important. The first stents we had were 130 to 140 microns, the Cypher and the Texas. The chances of restenosis were high in these stents, particularly chances of late stent thrombosis, which happened after 1 year, and that what was found was incomplete endothelization. And that is where the race began to reduce the strut thickness in a stent. Over the period of time, there has been significant improvement. We have first, second, and third generation. We now have really thin stents which are 70 to 18 microns. We have ultra thin stents which are less than 70 microns. And the most important aspect, how that happened, was to change the overall platform. The first was a stainless steel stent, and then we moved towards cobalt chromium and platinum iridium. Both of these, we could maneuver the stents to lower strut thickness. They were thinner, they had good radial strength, they had improved radio opacity. So your cobalt chromium are your Zions group of stents, the second generation, and even the Endeavor stent. The platinum iridium is 90% platinum and 10% iridium. Because of the iridium, there is excellent radio opacity, there is reduced thrombosis, neointimal hyperplasia, less inflammatory reaction. But these stents do have a higher recoil, like recoil was seen as compared to the stainless steel, the recoil was around 16% more. Now, what is the rationale for biodegradable stents? So, we know that stents are only required for the first 6 months till the remodeling of the heart, the coronary artery happens. After that, they are practically not required. So, we wanted a stent which could just get dissolved after it does its work, and that improves or that eliminates your early and late complications. It restores the vasoreactivity of the artery. That was one of the most important concept, that the arteries are breathable, they change. And once we put up a metal stent, we actually do not allow the arteries to dilate as much as what it should be. And when there is a biodegradable stent, it would help into the context. But in this case, because of the tortuosity and biodegradable stent would not be the first option. Maybe we can have a discussion on the same. Now, what about flexibility and radial stiffness? More the flexible the stent, so how do you increase the flexibility? You reduce the connectors, you get open cell designs, what we will discuss further. So once you increase the flexibility, so you reduce the number of connectors, and that will reduce the radial strength. So flexibility of the stent and the radial strength would go vice versa. And we have to find a right balance so that there is not much of recoil, not much of malapposition, and we are able to deliver the stents better. Now, my first concern in this case was tortuosity. If there was no significant calcium, I would have selected ultra-thin stents less than 70 microns. Ocero tetrilimus are the best. Just 1 minute. The benefits would be deliverability, better endothelization, vascular healing, and reduced stent thrombosis. If there would have been if there would have been calcium, newer Zions, Onyx, Ultimaster, Synergy, which are 81 to 75 microns, particularly ultra-thin would not work, or these stents would be better if there is an ostial lesion, there is calcium, and there is a CTO where radial strength is important. The second concern is large OM. So for that, open cell design and hybrid cell designs are better. These are some good stents with open cell and hybrid cell designs. What is open and closed? You can see there are some in-between connectors which are missing. That opens up the cell. It helps in recrossing the wire. It helps in maintaining the patency of the side branch. What is hybrid cell design? It's an hybrid. The distal part or the proximal part is closed cell, and in between there is open cell, because that is where your maximum branches are going to be there. With open cell, we would reduce the radial strength, but at the same time, the flexibility and side branch access of the stent would improve. With closed stent, the radial strength would be on the higher side, but the chances that it would be more stiffer and more the side branch access would be difficult. Closed cell design stents are not used much here. I'm out of time. I would like to close it. The impact of stent design on clinical outcome is intra-deployment of the stent, which requires consideration of vascular injury, because if you're going to push and pull the stent, if it is a stiff stent, you're going to damage the vessel. What is the deliverability of the stent? What is the structural and longitudinal integrity? And what is the expansion quality? Post-deployment, what do I really want from my stent? There should be a continuous scaffolding to support the artery, bending flexibility, stent fatigue, because the stent is going to have a cyclic loading and unloading over the period of time. Most of the stents go for a 10-year stent fatigue. and what's the arterial coverage? Thank you.
Thank you, Priyank, for a nice presentation. Now I would like to uh, invite Dr. Ladda for the drug platform polymer. They are more important determinants with availability of newer delivery systems and catheter.
Good morning, all. Good morning, Chairperson and Moderator. So, my part is to talk about the drug dose and the polymer in stent selections. We know that this is a 50-year-old doctor and diabetes. He is a diabetic and unstable angina, the tortuous course of circumflex. So considering the type diabetes, we know that the diabetes is having 2 to 3-fold increased risk of developing cardiovascular disease compared to the non-diabetic. And that is because of the aggressive atherosclerosis, diffuse lesion, and the small coronary arteries in the diabetic patients. And these the complications caused by mainly because of the dysfunction of the vascular endothelia and the smooth muscle cells and the generation of the thrombus. So the causative factor, in particularly in diabetic patient, because of the accelerated atherogenesis, blood abnormality, the platelet dysfunctions, hypofibrinolysis, and hypercoagulability. So these are the main diabetic related issues that we have to consider while selecting the stent. Now coming to the limitation of the current DAS in the diabetes, because of the delay vessels healing due to the slow endothelizations and the increased inflammatory response in the diabetic patient that lead to the focal to the diffuse stenosis and the acute to the late thrombosis. Now, this is the general understanding about the stent. We know that the 4 part of the stent, that coating, which is essential for the protection and the carrying of the drugs, and it control its release as well. And the drug part, which is the prevent the proliferation of the neo-intimal hyperplasia, and the stent for the deliver the stent to the target lesion, and stent is the scaffold, the vessel, and it carry the drug and the polymer itself. So these are the 4 components of the drugs, and after delivering the stent, the longevity depends on the coating as well as the drug part. Now, my talk will be on the drug doses and elution and the role of polymer in the drug eluting stent with clinical outcomes. Now, the drug doses and the elutions, the role of anti-proliferative drugs to stop the vascular smooth muscle cell proliferation as well as which is the neo-intimal hyperplasia, and the sirolimus and paclitaxels were the first used in the first generation test. We know that the sirolimus arresting the cell cycle in the G1 phase. And in all the clinical trial like the Reality, Siratex, and the ISAR Desire, the sirolimus has outperformed against the paclitaxel, even though both are inhibiting the cell cycle, but because of this release kinetic, dose, and the immunosuppressive properties, which outperform the sirolimus compared to the paclitaxel. And the drug kinetic, the vascular smooth muscle cell start to proliferate after 24 hours of stent implantation and which continue beyond the 2 weeks. So we need a drugs which can deliver up to 3 weeks after the stent implantation to prevent the smooth muscle cell proliferation and the migration into the stent. The current drugs which is available, the sirolimus, which is in the second generation of this stent, and after that the variant of the sirolimus like the jotarolimus, everolimus, and the biolimus. In all, the jotarolimus is a more lipophilic and property and the low water solubility, and it lasts longer. It never burst. It never burst in a row. And everolimus also more lipophilic and absorb to local tissue more rapidly and has a longer cellular resistance time. Paclitaxel and other drugs which is not we use nowadays. Now the role of polymers, we know that polymer it stabilizes the drug on the stent and it modulates the drug release. And once the drug is released, there is no role of polymer. Rather, because of the polymer, there is a late complications of the stent, which is like chronic inflammations which lead to neoatherosclerosis, or constant irritations may lead to the late stenosis. So evolution of the DAS in coating part, the BMS from BMS to first generation, that is the durable polymer stent. In the second generation, that is the biodegradable polymer stent. And the third generation stent where there is no polymer, the polymer-free DAS. And in the drug delivery part, that is divided into the biodegradable and non-biodegradable. Non-biodegradable in the first generations and in the second generation in the giants, that is the fluoropolymer, and in the endeavor category, that Medtronic, that is the phosphorylcholine category polymer. The biodegradable polymer, that polylactic acid, polyglycolic acid, and polylactic glycolic acid. These are the biodegradable polymer, which is nowadays in all third or fourth generation stent, we have that. In the non-polymer, which the titanium, nitric oxide alloy, or the microporous stainless steel stent of Yukon, these replace the polymer. These components are, these materials are used as in place of polymers. Now, the types of polymer in giants, we have drugs everolimus, and the polymer is the fluorinated polymer, which is a delay release polymer. And the Resolute, the Medtronic, again it is a jotarolimus drug, and the BioLinks, that is also a delay release polymer. In Synergy and Ultimaster, the polymer is a biodegradable polymer. In Orsiro and Nobori and Biometrics, in all three also the biodegradable polymers. The elution time that lasts from the 4 months to the 6 months, 120 days to 180 days. That is also in all the new generation of this stent. Now, abluminous. Abluminous stent basically is a thin stud stent, and mainly it is a design in that way that it is polymer is a biodegradable polymer, and the coating is abluminal coating, and drug is the sirolimus. And this stent is CE approved for the diabetic patients. You see in the abluminous stent, there is abluminal coating. The coating of the polymer is the abluminal side, means the side stent where the stent is placed to the lumen vessel side. Lumen side is bare metal side. And other than this, the exposed part of the balloon in the stent, which is also coated with the drug. So that's why it is a N-resolution technology, where abdominal coating as well as a fusion coating with the DAS and DCB coating, both the technology is used. Now, the polymer-free drug delivery, where there is no polymer, even drugs fills hollow core of the stent, and that slowly released from that stent. And drug eluting technology progress from the current DAS to the Synergy DAS, means in previous stent, the drug polymer is coated with the whole stent with the drugs, that is replaced with the luminal coating. The stent part, which is attached to the vessel wall, it is coated with the polymer and drug, and the luminal part is the bare metal part. Now, after understanding all these things, then I thought which stent will be better for this guy. And that answer I got from this paper, that comparison of the contemporary all drug eluting stent, is any stent better than the other. And what I found that all stents are really comparable. You see, BioFlow these are the all study which compare with the bioresorbable polymer versus the permanent polymer coating. If you compare, the first study is the BioFlow study, where the Orsiro is compared with the giants, where Orsiro is slightly better in numerical value, otherwise it is also comparable. Bionics also with Orsiro and Resolute, the same thing with the result is also same, comparable. BioResort with Synergy and Resolute, the 12-month data is also comparable. The Bioscience with Orsiro and Giants, that is also comparable. So if you name the study and then see the result, almost the stent thrombosis and the primary endpoints are comparable with new generation of this stent. Now, this is the randomized control trial that comparing the drug eluting stent, eluting different drugs. Like first is the everolimus, and that compare Nobori versus Giants, and the study shows 5.2% versus 4.8% cardiac death, MI, that is also comparable. The basket proof study also, that is also a comparable. So in almost all the clinical trial, the end results are comparable. Not a single stent has outperformed the other one. there is in somewhere, some numerical values are better in some segment, otherwise all are comparable. Now, to conclude, the drug-eluting stent, the DES technology has progressed from thick polymeric drug-eluting coating to the thin polymeric drug-eluting coating, and from durable polymer to the biodegradable polymer, and finally, the polymer-free coating. And to reduce the stent thrombosis and the myocardial infarction in the second generation as compared to the first generation, we know, and that further reduce the low-late stent thrombosis incidences in third generation of the DES. And the third generation DES solve the polymer-related issues because of the biodegradable polymer, and even introduce more advanced technology of stent where polymer is no longer needed. So at this moment, we have a diverse range of drug-eluting stent that are performing extremely well, and we can choose according to the patient's category, anatomical lesions, as well as longevity of that stent. Now, in future, we may see the different drugs on the stent made to combat restenosis or to prevent the increase the endothelial healing or the combination of the drug. That there may be some kind of these newer things we may see in future. Thank you so much.
Thanks for that lucid presentation, both of you. So basically in the cath lab, in a patient, we have to marry the two concepts, right? So you have to select a good structure and you have to select a good drug. So now this patient you guys already knew. I mean, Kamal sir has already told you that ऐसा patient आ रहा है. So what is your conclusion for this patient? And my next question to both of you guys is, I mean, what I understood from your presentation is that you wanted abluminous, probably. No, you wanted abluminous and you wanted biomime, right? Now, both the things are poles apart. So now if you have to marry, which would be the one stent that you want to deploy in this patient? Both of you have to give a common answer.
Yeah, because basically you need a stent which can easily crack your lesion, easily deployable. Once it is deployed, it should last longer. It should not be late or acute events, and that's why I have chosen that stent. Yeah. Yes, definitely. Once it's enter.
Sir, which would be the common?
True.
Please, mic, please.
We as doctors debate. So the two basic problems with the stent or evolution of stent was one, to make it thinner, the struts be made thinner so that rapid endothelization and trackability improves.
But you cannot go beyond certain limit, otherwise the stent will break.
Yeah, just one. Yeah, so till that 60, 70 microns. And the second one was to remove the polymer because we had untoward side effects to polymer, and polymer was not required. It was just a binding thing for the drug and the stent. Polymer basically was no way out. So the context is, so Priyank and Mukesh will have a debate on the same, but stent companies want Priyank also in their fold, they want Mukesh in their fold. So the evolution of the stents happened that both improved simultaneously. The stents
so Priyank, that's a very diplomatic answer.
Deliverable and thinner at the same point of time, the polymers, because most of the, as Mukesh just
so
showed
we'll take
in
the
his
opinion of the experts, like
lecture.
what would be the one stent that all of them would choose? I mean, all three of you would. One stent that all three of you agree.
I think when it comes to better trackability, deliverability, and good stent thickness, I think Onyx will score a lot higher compared to other stent types.
So we also tend to disagree. We think synergy is the one stent that would go in this case.
I would choose Ultima.
But as sir has already shown, Mukesh bhai ne jo dikhaya hai, all stents are same at the end of the day. So it's your DAPT regime which is also contributing to a good clinical outcome, and we can never segregate which drug or which polymer or which stent. It's all our experiences that we bring on this forum, and that's how we proceed.
Another question that I would
In
like
fact,
to
the
ask is, there is
patient profile itself also carries. We have recently done the check angiography of Cypher stent, which was deployed almost 20 years back, and they were patent. And synergy stents getting blocked, so it's not only the stent and polymer characteristic, the patient characteristics also matters.
another thing that is very important over here is the side branch coming across the lesion. So in case if you have to go for a bailout bifurcation strategy, will the stent choice matter in that case? Will you, choose a different stent or?
You would want an open cell design or a high open cell now, even Sierra is now open cell. Of our good stents, what we discussed, Onyx, Sierra, Synergy, they are all open cell. The side
generation
branch
all are
access is
having-
very good with them.
So basically, it's a operator choice with what we are comfortable and with what we are having a long-term our own satisfaction. Currently, as Mukesh has said, most of the saints, they do perform equally. Even in a PMGI era, we have seen that they see DAS also equally performing in the patient. So you should be comfortable with whatever you are doing. Regarding the trackability and deliverability, we have so many gadgets. And over the periods of the experience, we can deliver any stent at any place. So that is not the matter. Here, the polymer-free versus a biodegradable polymer, that is very important. And definitely, thin strut stents are now in the market, and we are using it since long. So, being a doctor, I will definitely go for US FDA approved stent rather than a CE approved stents.
Yeah, I think this case was deliberately given for two reasons. One was tortuosability, and so that trackability will come up. And second would be the side branch access, because there was a large OM coming across, as we said. So when it comes to both the parameters, this is the quiz that I've put. Open cell, thin strut versus lesser connector and cell size and shape. What matters most is the lesser connectors. Actually, we can debate how many, which stent is better, etc. Thin struts do matter, but lesser connector will also lead to stent fracture. So it's a very delicate balance between stent fracture and open cell design with lesser connector giving better access. And also, of course, the side branch diameter will be ordered by the struts. So thinner struts, all will play a role. Of course, I strongly believe polymer is a bad thing. So at least completely biodegradable polymer or is something that I always prefer, because we know from Renu Varamani series, autopsy series, and that's the reason why ciphers have been withdrawn, that these are like plastics. They stay forever in your endothelia, never get endothelized, never get endothelized. And the best wall for any artery is endothelium. If you can get endothelium, that is the good stent. So whichever stent gets good endothelium, preserves the side branch, has thin struts, track easily, rather than naming any one stent company, I would say that's the stent you should choose. Idea was to teach what you should be looking out for in a stent rather than commercial angles also.